Thank you so much. We can go on now. Question 1 up to 5, we are going to be using this scenario. You are an anesthesiologist on call at Kasama General Hospital and you are called at midnight to attend to Jen Mlenga, a 24-year-old preemie gravida at term who has been diagnosed with fetal distress in labor and needs an emergency cesarean section in theater. You have planned to give her spinal anesthesia. What is the anatomic landmark for giving spinal anesthesia? L1, L2, L2, L3, L4, L5, L5, S1. N1. Which landmark are we going to be able to use? Let's be free to speak. The quicker we answer or try the question, the faster we go. Pardon? B. Thank you so much. And I think what is important for us to understand is why not the rest of the answers, right? Would you help? Why haven't you picked the other options but picked B? Any suggestion? Any explanation? Anyone? Okay. Thank you so much. Is there anyone else that has got an answer that they are thinking? Anyone else? Remember, the more we speak, the better. Anyone with a thought? Guys, is it that we just don't want? Pardon? Why? So this is why we need to interact, because different people would choose a different answer and we want to now get to a consensus where we pick something for us all and why we have picked it. Yes, Doc, why would you go for that one? Hmm. Okay. Mm-hmm. Okay, thank you. So let's try to see. Uh, Here is the spinal cord. In adults, the spinal cord ends at the junction between L1 and L2. And you know, when you are performing a lumbar puncture, you're going to locate the iliac crest. That is at L4. So when you locate L4, you are now going up. So up, you are going to L3, and you are going to that intervertebral space. So that intervertebral space you are going to is which one? Is going to be between L3 and L4. But because the spinal cord in adults ends between L1 and L2, meaning that it is ending somewhere here, meaning that you can use this space for spinal anesthesia L2, L3, or you can use this space L3, L4. It is going to still be fine. When you look at children, their spinal cord ends at L3. So that's L3. You can't put a needle anywhere here because you are going to press on the spinal cord and that will injure it. Someone can become paralyzed. So the only landmark that we can use there is a landmark down, like the L3, L4. You again don't want to use these ones which are down, like the AC between, because as you go down, you're going to have S1, S2, and then you have got those others. You don't use those because mostly the intervertebral disc is strong, like it's strongly held. So the needle will find it very hard to pass when you're trying to push it. That's why in adults, the best you can use is L2, L3, or L3, L4. In children, it is L3, L4. So that's why that is going to end up being the best. Okay, so let's do this. When you're talking about this guy, the spinal cord, the blood supply to the spinal cord, there are three main guys. Number one are spinal arteries. Okay, spinal arteries. About spinal arteries, you are going to have one that is going to be anterior and two that are going to be posterior. So you have got one anterior spinal artery, and then you have got two posterior spinal arteries. Remember when we are forming this, look at this. This is the vertebral artery coming from the subclavian. And even this is the vertebral. When they joined these guys, they formed the basilar. Remember that from the vertebra you had this artery, the anterior spine. It's only one. But the posterior guys are the two of them. Okay. And then another. So these guys, the spinal arteries, the anterior and posterior, they are branches of the vertebral artery. Please take note that these guys will only supply the spinal cord up to the cervical end. Cervical. And then the next are going to be the radicular arteries. The radicular arteries also, you are going to have the anterior branch of the radicular artery and the posterior branch of the radicular artery. Since the spinal artery only ended in the cervical, how about from the cervical going downwards? So what is going to supply the cervical going downwards are the radicular arteries. And you are also going to have what is known as arteriovascular. Arteriovascular. Now the arteriovascular is these are branches. It's a plexus of arteries that will penetrate deep into the pia mater to be able to supply the inner part of the spinal cord. Now about the artery of Adam's quiz, what happens is this. Let's make it interesting. So here is the arc of the aorta, and then you're having the abdominal aorta coming down. So from the arc of the aorta, starting first from the subclavius itself, and then the vertebral arteries, even the abdominal aorta, the aorta itself, starting from thoracic, abdominal, you are going to have these branches. Depending on the region, you are going to have thoracic, vertebral arteries, you are going to have lumbar, you are going to have sacral, you are going to have the intercostal, all those depending with the region, but they are all the same coming from the aorta. So what happens that these arteries, let me just get one of them. So let's say we get this one, okay? And let's say this is intercostal artery. And it is, you remember the intercostal arteries, you are going to have those which are going to come in anterior to supply the the intercostal spaces in front, and then you're going to have that guy that is going to go posteriorly, and the guy that is going to go posterior is actually going to supply the spinal cord. So you're having a branch from here, the posterior intercostal artery. Now the posterior intercostal artery, what it's going to do is that it will give out a branch that will supply the bones, the vertebral. So we're going to have a vertebral branch, and then you are going to have now this branch that is going to the actual spinal cord. So this is the spinal branch. Now the spinal branch further is going to divide into radicular arteries. So we're going to have a posterior radicular artery, and then you are going to have anterior radicular artery. Okay. The biggest anterior radicular artery is what is known as the artery of Adam-Kiwis. It's also known as arterio radicularis magnum. It's a biggest. And where are you going to find this guy? You are going to find it in the thoracolumbar region, either between T11 and T12. That is the thoracolumbar, or L1 stroke L2. This is where you find this artery. So now that we have said that the artery of Adam-Kiwis is a branch of what? Posterior radicular, anterior radicular, anterior spinal, or posterior spine. Okay, now pick an answer. Are we together, guys? Now that we've mentioned everything here, so which one can we pick since we've talked about it? hmm So I'm not even. I've heard one at the anterior radicular, and then there's the other doc who was speaking. The network was cutting. Okay, the answer is anterior radicular, guys. So remember, thank you so much. That's the answer. Anterior radicular. Remember the spinal arteries only supply the cervical, and we are saying this guys is in the thoracolumbar, so it can't be spine. All right. So question 3. After your needle pierces the ligamentum flavum, the next structure to pierce is the dura mater, arachnoid mater, subdural space, epidural space. Anyone to help with this one? Epidural space. Thank you so much. Let's just try to make sense of it instead for our friends and ourselves. so that it won't give us much problems to remember. What I'm trying to put here are vertebral bones. And these things I'm putting behind, these are spinous processes. So when we are penetrating with a lumbar puncture, what is the first thing that we encounter as a need to penetrate? It's a skin. Thank you so much. So we are passing the skin there. And then the next space, what will be the next layer that we are going to penetrate? Thank you. This space here, which is a subcutaneous tissue. And then after the subcutaneous tissue, can you see this ligament which is attaching to the spinous processes? What is the next structure? So, so this is now what I want us to be able to use, right? Before inter is between. So this is the spinal. This is a vertebral board. This is a vertebral board. You have got this ligament between the bodies. That is the interspinous. Actually, not even the body itself, just the spinous processes. This one, but you can see that this one is on top. It's more superficial to the spinous process. So, what do you think will be the name? Yes. So you first have the supraspinous, and then now you're going to have this one which is between the spinous. So that will be now the interspinous, and then you are going to have another ligament which is inside like that. So what's the next structure? That's the ligamentum flavum. Now after we penetrate this ligament, now we are going to go to the meninges. And for the meninges, you can use a DAP, dura mater, arachnoid mater, pia mater. But then, let's say this is the dura mater. On top of the dura mater, we have got this space. What do we call this space? It's on top or it's outer to the dura mater. It is thank you so much, epidural. And then after the epidural, now we go to this same structure. What is the structure here? It's the actual dura now. And after dura, remember, we are now going to this guide, DAP. After D, we are going to A. What will be the A? That will be the arachnoid. Thank you so much. Arachnoid. And then below the arachnoid, what is this space going to be? It is below subarachnoid, isn't it? Yes. So basically, those are the layers. So we are saying that here, after the ligamentum flavum, we have got the epidural. At what angle and direction should the operation table be tilted to ensure an effective and safe spinal block? So at what angle and direction should the operation table be tilted to ensure an effective and safe spinal block? Anyone to help with this one? You know when you're okay, thank you so much. Why have you picked C, Doc? Any suggestion? Why have you picked C? Oh, okay, thank you so much. So this is the person, you can see the person is tilted forward like that. And say this is the line that you are using. So you are pushing your needle like that, right? That's how it pushes into towards the umbilicus. It's 15 degrees head side higher than foot side. All the following are potential complication of a high spinal block above level of puncture site, except. So what happens if you have performed, let's say, the anesthesia, and then all the nerves above, above your L4, L5, above where are you going? You are going all the way to the brain. So what will be the complication? The stroke. So all of these are going to be complications except so stroke, blood dyscariasis, cardiac arrest, respiratory depression. Which one can we pick? Which one is the exception? Which one is the exception? Why, doc? Thank you so much. Basically that. So we can have a stroke because there is no innervation upwards, right? Like upwards. And from your L4, L5, going all the way up, you are having the brain. There's no innervation there. Someone can have a stroke. Or all the structures up there are not working. Someone can have a stroke because you're not controlling other parts. For see cardiac arrest, you know that the heart also has got innervation. The innervation of the heart is also coming from the nerves up, right, on top of L4, L5. So if you lack innervation, the heart will stop pumping properly. It will actually stop working, though it has got its own intrinsic activity, but it has got some extrinsic nerves like the vagal inputs. Respiratory depression. Remember, the respiratory centers are found in the brainstem. So the brainstem is not also working. Why? Because there is a block. But blood dyscariasis. These are just blood disorders. Things like leukocytosis, those problems because the bone marrow is not producing blood. But how has the production of blood to do with nerves? So that the effect isn't going to be there. So that one is out. Number six, fibers from the fornix are projected to the mammary body via the A precommissural fibers, B anterior commissure, C posterior commissure, D fibers to the thalamus. Anyone that can help? Anyone? The posterior commissural fibers. Why do you think so, doc? Any thought? Any thought? Remember, I always ask this question, why do you think so? Because we should be able to differentiate. Imagine maybe for whatever reason you didn't find that same answer you are suggesting. Maybe they put some words that is explaining the same answer. Yes, please, Doc. I heard someone was saying I also support. Okay. All right. So let's describe it a bit. Mm. You know the phonics. We c- let's see if we can draw it. So this structure is what we call the phonics. At at the end here, we have got the hippocampus. So basically, the phonics is connecting the hippocampus to these structures, which are part of the thalamus, the hypothalamus, which we call the mammillary bodies. So there are two, these two mammillary bodies. Now the hypothalamus, the hippocampus is going to be connected. First, you are going to have two structures which you call the fimbrae. You have got this and that, or fimbria. And then you are going to have these structures on top. So I've got two fimbrias. You go on top, you are going to have crews. You have got two crews, and then you have got a body, and the body is only one. And then at the end, you have got these two structures. You call them the columns. So you have got two columns, and then you have going to have the mammillary body. The mammillary body will also connect to the thalamus, specifically what we call the anterior nucleus of the thalamus. Because we're coming from the mammillary body to the thalamus, we call this as the mammillothalamic tract. It's an important part of the Papez circuit. Okay. So coming to this end, the mammillary, so we are saying the fibers from the fornix are projected to the mammillary body, and this is the fornix. You are going to the mammillary body. So you are going to have the postcommissural fibers, yes. I want you to go and look at a diagram properly. You are also going to have the pre-commissural fibers, but the ones that are going to be ending here are the post-commissural. Please just go and check through the diagram so that you see how the pre-commissural fibers are moving, and also the anterior. So the anterior commissural fibers, if I remember well, those are somewhere at the end here. Let me not lie, because the structure is frustrated there. Which hypothalamic nucleus is regarded as the master clock of circadian rhythm? Paraventricular nucleus, anterior hypothalamic, suprachiasmatic, preoptic. Thank you so much. The suprachiasmatic. It has got actually a relationship with a certain part of the epithalamus. No, that gamma part that is involved in sleeping, which produces melatonin. 8. Regarding the Papez circuit, fibers from the thalamus are projected to the cingulum via. Okay, let's talk about the Papez circuit. Papez circuit is a circuit of emotions. You are coming from the. It's easy. You are coming from the hippocampus, coming from the hippocampus and going to the hippocampus. That is the journey basically. So we have already said that from the hippocampus. Where are we going? Supposed to be two P's. Anyone? From the hippocampus, where do we go to? Okay, specifically the mammillary bodies of the hypothalamus. Yes, thank you so much. And what path are we using? How are we connecting the hippocampus to the mammillary body? What are we using? Remember the phonics. Remember, this is what you're talking about just on top. And then from the mammillary body, where are we going? I also did mention it. Anyone? Thank you so much. The anterior thalamic nucleus. And what are we using to go to the anterior thalamic nucleus? What fibers? Thank you so much. The mammillothalamic tract. And then from the anterior nucleus or the thalamus, where are we going? Where are we going? Yeah, to the cingulate gyrus. Thank you so much. Thank cingulate gyrus. And then what are we using to go to the cingulate gyrus? Yes, the internal capsule. And then from the cingulate gyrus, we are going back to the hippocampus. What are we using? The name is similar to the cingulate. Cingulum, yes. So this is the Papez circuit. So regarding the Papez circuit, fibers from the thalamus. Remember, the thalamus is specifically the anterior thalamic nucleus. Project to the cingulate gyrus via the. So which one is the answer here? A, B, C, D. Someone to surprise us, though, especially those who don't like speaking. Just say something. Which one is going to be the answer? It's the internal capsule. During the development of the brain, the following represent the sensory areas: mantle layer, basal plate, sulcus limitans, ala plate. Which one can we pick? If I say something about it, you don't answer, then I'll stop saying something about about them. So we have formed our neural tube. This is our neural tube, and this is formed like in which week is that? Week 3. There in during neurulation. When you form the neural tube, you can see this space here. You have got these epithelial cells of that form the neural tube, and we are calling those as the neuroepithelium. So what is going to happen is that after the neural pores close, the anterior and the posterior, we know that the posterior takes a bit of time to close, right? Like, is it on the 27, 28, and then the anterior closes on the 24, 25? So the neuroepithelium is going to start giving rise to some cells. You know, the neuroepithelium is that same epithelium that I showed inside the neural tube. It will start giving rise to some cells, and what you are going to see is a structure like this. You still have your neural tube there with its neuroepithelium. Okay, so what I've put there is the neuroepithelium. This neuroepithelium is made up of pseudostratified cells, which will start giving rise to neuroblasts. And those neuroblasts are going to form what is known as the mantle zone. This mantle zone is going to later on give us gray matter. Gray matter. Okay, the mantle zone. So you are going to see it differentiating. The mantle zone is going to differentiate on the left side and on the right side. And they are going to be divided by what we are calling as the sulcus limitans. These guys. So anteriorly, so this is the mantle zone. All these four things that I've shaded is coming from the mantle zone. But now we have separated it because of more development. And anteriorly, we have got what we call the basal plate. Posteriorly, part of the mantle zone, we have got the ala plate. And we have got this outer portion that remains is going to be what we call the marginal zone. The mantle zone has formed the gray matter. The marginal zone, which is outer, will form white matter. And you are going to have the sulcus limitans there. Okay. In the front here, we're going to have what we call the floor or the floor plate, and then this side we're going to have the roof plate, which is somewhere posterior. This structure is furthermore going to differentiate to become a more like a structure that we can relate to, something like that. And then the zones that we also saw are now differentiating into the functional parts. And so here you are going to have this part, which is the posterior horn. You have got the lateral horn, and then you have got the anterior horn. You know the anterior horn is motor, the lateral horn is part of the autonomic nervous system, right? Sympathetic and parasympathetic. While the posterior horn is a sensory horn. So the ala plate, which is posterior, is the one that forms the posterior horn. The lateral horn and the anterior horn, they are going to come from the basal plate. That is why the nerves, sympathetic nerves and parasympathetic nerves, when they come from the lateral horn, they are going to use the anterior route instead of the posterior route. The posterior route is sensory. Okay, take note of that. Okay, this is the basic thing. And then for the nerves, you start first, you are going to have a neuron, a bipolar neuron, and then this bipolar neuron will send processes that are going to join there, and then it will send the other processes, the peripheral processes, to attach to the organ. That's how those are going to form. They start as bipolars, and then they can end up the way they are ending, like this one is pseudo unipolar. Okay, so now we know. During development of the brain, the following represent the sensory area: mantle zone, mantle layer, basal plate, sulcus limitans, ala plate. Which one are we going to pick? Thank you so much. So the ala plate. The recurrent branch of Hebner supplies the following parts of the internal capsule. Again, for this one, let me mention them and then we can answer properly. Please understand it from here and you'll not get it wrong anyway. Any time. So the internal capsule, we know it has got these parts. So you have got the anterior limb. I'm going to just put that's the anterior limb. On the middle, we have got the genu, and then we have got the posterior limb. And then after that, connected to the posterior limb, we have got the sublentiform part, and connected to that sublentiform part, we are going to have the retrolentiform part. So this is a sublentiform, this is the retrolentiform. Now we know our circle of Willis. How am I even going to put it? So we have got the basilar guy going like that, which is going to give us these structures. We are calling this as the posterior cerebral, and then we are going to have the posterior communicating. We have got the internal carotid there, and then we are going to have the guy here, which is the anterior cerebral, which will continue like that, and then it's giving us anterior communicating. And then from the internal carotid, this one on top, we are going to call it middle cerebral. This one that I've written on the down aspect, we are calling this as the anterior choroidal. Okay, please take note. So let me just label them so that they will not confuse us. This is the anterior cerebral, starting all the way from here, going like that. Anterior cerebral. This guy itself, the circle, is the internal carotid. And then the one that is going up, we are calling this as the middle cerebral. This one is the anterior choroidal. Choroidal, not cerebral, but they are more using C's. Hope you differentiate. And then this is the posterior cerebral. So these are the main guys. So the first thing, let's start with the anterior cerebral. From the anterior cerebral, let's get a branch from here. We are going to have a nice branch which we call the striate branch of the anterior cerebral. The striate branch of the anterior cerebral only takes blood to the anterior limb of the internal capsule. Please take note. And then this is the striate branch of the anterior cerebral. From the anterior cerebral, we're also going to have the recurrent artery of or the recurrent branch of anterior cerebral, which we also call as the recurrent branch of Hebner. That guy is going to send, look at how it comes, it's a good guy. It is going to supply blood to the anterior limb, to the genu, to the posterior limb. Okay, that is the recurrent branch of Hebner, or the recurrent branch of the anterior cerebral. We are going to have other guys. So coming from, remember this is the middle cerebral. Coming from the middle cerebral, we are going to have also another striate branch, but that one we call it as the striate branch of the middle cerebral. Please pardon me for this one. Let me correct this error. Okay. For the recurrent branch of Hebner, it doesn't supply the posterior limb. I was explaining the middle. So the recurrent branch of Hebner is only supplying the anterior limb and the genu, but the striate branch of the middle cerebral is the one that is going to the anterior limb, going to the genu, and going to the posterior limb. Hope the data that I said earlier is rubbed and then you have put in this new data. So that is the striate branch of the middle cerebral. And then coming direct from the internal carotid, you are going to have a branch direct from the internal carotid that is supplying the genu. This is a direct branch from the internal carotid. And then coming from the anterior choroidal, you can see here the anterior choroidal, you are going to have a branch that is going to come and supply the posterior limb and the sublentiform part, just these two parts. Okay, that is coming from the anterior choroidal. And then coming from the posterior cerebral, this guy is good. Just like the middle cerebral, the striate branch coming from the middle cerebral, supplying three parts. It is also going to supply three parts. So which parts are those? So this guy is going like this. It supply everything which is more posterior. You can see you have got the retrolentiform part, you have got the sublentiform part, and then you have got the posterior limb of the internal capsule. So this is the blood supply to the internal capsule. This guy we are calling this artery here. This is the posterior cerebral, supplying retrolentiform, sublentiform, and posterior limb. And then this one here that we can see is, you can see it's coming from the middle cerebral. So that's basically the middle cerebral artery. And sorry, from the anterior choroidal. So this is the anterior choroidal. The anterior choroidal is coming to supply the sublentiform and the posterior limb. A direct branch from the internal carotid is supplying only the genu. And then coming from the and middle cerebral, which is a striate branch of the middle cerebral, supplying the posterior, genu, and anterior. And then you have got this guy, the recurrent branch of abnon supplying the anterior and the genu. And then the straight branch from the anterior cerebral is only supplying the anterior limb. Okay. So recurrent branch of Hebner supply. Okay, so this one is actually the anterior choroidal itself, which is supplying the posterior limb and the sublentiform part. And then also the branch coming from the so this one they've just said is the direct branch, a direct branch from the internal carotid, no special name. All right. So now we can answer what is the recurrent branch of Hebner supplies what? Anterior limb and genu only, anterior limb, genu, posterior limb only, sublentiform, retrolentiform, posterior limb. Anyone that can help? It's A, right? Thank you so much. That is the answer there. A. Okay, question number 11. The upper motor neuron impairment produces the following changes of muscle tone. Let me also mention this guy. Look at these doctors. Here is our brain. There is our brain. So the let's say here is a muscle. Here is the muscle there. Okay. And you are having nerves that are coming from a muscle going to the spinal cord. This guy is known as a lower motor neuron. We are going to have now another nerve taking it from the spinal cord. Actually, when we are controlling muscles, we are talking about nerves coming from up, right? They are coming from the cerebral cortex. And these nerves are going to pass through the internal capsule, they are passing through the brain stem, and then they are coming here. You know, for descending nerves, they only have two nerves, right? The upper motor neuron and the lower motor neuron. For the ascending, those are the ones that are going to have three: first order, second order, and third order. So any lesion either on the cerebral cortex itself, internal capsule, even the midbrain, the crus cerebri, including the medulla, remember some, like the corticospinal passes through the pyramids. So if you injure the medulla or if you injure the lateral funiculus of the spinal cord, because that's where this nerve is passing like that, that is going to be an upper motor neuron lesion. Remember, we've said the lateral funiculus of the spinal cord, because from there, from the spinal cord, this nerve is going to come out, going to the actual muscle that we're innervating. So at any one point of those, you are going to cause an upper motor neuron lesion. And but the most important parts where a upper motor neuron lesion is going to happen is the cortex and the internal capsule. When those are injured, they're going to cause the upper motor neuron syndrome. And the signs for this syndrome, number one is that you can have paralysis or paresis. Paresis is basically weakness. So you can either have paralysis or weakness of movement of the affected muscle. That is for the upper motor neuron. Yes, please. Is that a hand? Okay. Number two, there's going to be hypertonia when it is upper. Number three, there's going to be spasticity. Spasticity is a resistance to movement in a single direction. So are trying to move, let's say, your limbs or something, there is that resistance. Number four, there's going to be abnormal reflexes like the Babinski's sign. Babinski's abnormal reflexes. Babinski is also known as the extensor plantar response because we are taking our toes up towards the plant. And then number five, so besides the abnormal reflexes, you can also diminish some other reflexes, like the abdominal reflexes are going to diminish. Besides that, there's also going to be hyperflexia, which is the myotatic reflex. Hyperflexia. Okay, so the upper motor neuron impairment produce the following changes of muscle tone: flaccidity, spasticity, cogwheel rigidity, myoclonus. Which one can we pick? Anyone? Thank you so much. So be there. Pyramidal fibers arise from Broadman area. I'm from just mentioning this guy. So the pyramidal guys, pyramidal tracts you have got two. The corticobulbar and corticospinal. They are passing through the pyramids of the medulla. And you know that on the pyramids, they are going to decassate there, right? If you remember. And because these are corticobulbar, corticospinal, they're coming from the cortex. These are motor. So in other words, which one is the motor area here? Area 312, area 8, area 4, area 18. Anyone? Thank you so much, area 4. What is area 18? Do you remember area 17 of occipital lobe? This is the association area for that guy. Thank you. So the association area for vision. Okay. Question 13. A patient has the ability to stand with open eyes but falls with closed eyes. A lesion of which pathway is likely responsible for this symptom? Dorsal spinocerebellar, lateral spinocerebellar, ventral spinocerebellar, dorsal column syndrome. Anyone? Dorsal spinocerebellar. Okay. Is there anyone with a different one? Or we are all good with that? Anyone with a different one or supporting that one? So there's also dorsal column syndrome. Can I have a third one? The third one is going to determine which one is which. That is if they choose any one of those two. Anyone else? Anyone? Let's be free to. Thank you so much. Okay, so we go for that. So that's actually one of the comparisons when you're comparing the cerebellum, injury to the cerebellum, and injury to the dorsal column. Remember, the dorsal column contains the the gracile tract and also the cuneatus or cuneus tract. Those are also involved in balance and in those touch and those things. So when you injure the dorsal column, that's the different thing. So there is a, what do we call this sign where we've been doing it in clinical skills? You have got a patient, you ask them to close their eyes and then you put your hands. If they fall, it is positive. What is the sign? Thank you so much. The rhombic sign. So a patient has the ability to stand with open eyes but falls with closed eyes. So you can see the rhombic sign is the positive when it comes to the dorsal column syndrome. But when it is the cerebellum, whether you open your eyes or you close your eyes, if the cerebellum is dysfunctional, you will still fall. You can't stand like that. So that the ventral spinocerebellar tract enters the cerebellum through the dash brachium conjunctivum tectus plate, cerebellar peduncle, rest from body. Anyone to help with this one? So there is A there. Anyone who supports? Anyone that is supporting? Okay, let me just mention this. The answer is A, it's correct. So when you're talking about afferent fibers that are going to the spinal cord, remember they are going to the spinal cord. So are going to have things like, sorry, they are going to the cerebellum, not the spinal cord, to the cerebellum because we're talking about balance. You are going to have those which are coming from the spinal cord, like the spinocerebellar. You have got the dorsal spinocerebellar, the ventral spinocerebellar. You also have the cuniocerebellar. So if you talk about the ventral, also known as the anterior spinocerebellar, it is coming from the muscle spindles, the Golgi tendon organs, and the joint receptors. And it is going to the cerebellum through the superior cerebellar peduncle. Now, the superior cerebellar peduncle is also known as the brachium conjunctivum. And this guy, because when you come from your, let's say you come from your muscle, you are going to the spinal cord. Here is your muscle. You are going to your spinal cord. Specifically in the spinal cord, for this anterior spinocerebellar, you are going to lamina 7, which are the spinal border cells in lamina 7. And then the tract is going to decassate just there. It will go to the other side. That will be the anterior or ventral spinocerebellar tract. And then it will continue going up. If it reaches in the pons, it will now be able to turn and go via the superior cerebellar peduncle to the cerebellum. Okay, so it went to the contralateral side, but while in the cerebellum, it will still turn and go again to the ipsilateral side. And then the dorsal, also known as posterior spinocerebellar, it's also coming from the same muscle spindles and those other parts. But the difference is that the ventral is carrying the information from the lower limb. The dorsal is coming information from the trunk and lower limb also. For it, when it goes to the spinal cord, it is going specifically to what is known as the Clark's nucleus of the spinal cord. It is also known as the nucleus dorsalis. And it doesn't decassate. The dorsal spinocerebellar doesn't decassate. It is going to go to this when you reach uh, the brainstem. It's now going to go to the cerebellum through the inferior cerebellar peduncle. The inferior cerebellar peduncle is also known as the rest from body. The cuniocerebellar also carries information from the upper limbs and the upper thorax. Okay, upper limbs and upper thorax. You see that it is more the same like the ventral, just the ventral was coming from lower limb, but the cuniocerebellar is coming from the upper limb. It's also coming from the upper limb is going to go to the spinal cord, specifically between C1, C7 and C1, and then is going to go on the ipsilateral side and then pass through the inferior cerebellar peduncle. The middle cerebellar peduncle is also known as anyone is also known as, since the superior is the brachium conjunctivum, the inferior is the rest from body. How about the middle? Anyone that remembers the name when we discussed the cerebellum? All right, so it's known as the brachium pontis. Remember, the middle is connected to the pons. Number 15, Brown Sequard syndrome develops with the following damage of the spinal cord: complete transection, anterior horn, half transection, posterior horn. Brown Sequard. Why? What? Which of the following damages of the spinal cord leads to that condition? Thank you so much. So, in this condition, it's only half of the spinal cord. A patient with left homonymous hemianopia will have a lesion in which part? I don't want you to struggle in identifying. Let me just draw the pathway so that you can be able to identify well. So these ones I've drawn are are what? Are fields. Your eye field, visual fields. This is going to be the eye going like that. Okay, so let's say that's the eye. And here from this is your left visual field, this is your right visual field. From your left visual field, you have got the temporal that is going to go to the nasohemiretini, and then it will continue on the to continue like this, going to bifurcate, and then it goes to the contralateral side. Same with this side, it is going to go to the other side. And then for the nasal fields will maintain the ipsilateral side like that. In this condition, I've got lefty homonymous hemianopia, meaning that this left side is dead, this left side is dead. So you can see there is actually a lesion at this point if those 2 points are supposed to be dead. So which part is a lesion? The insular, frontal lobe, right parietal lobe, right temporal lobe. Which one can we pick? In other words, where do you find the right optic tract? That's the basic question. Anyone? It's the right temporal. This one? We know the temporal is down, right? There's also another doc who was saying something. Let me first hear from also him. Anyone else, guys? Okay, it's the parietal lobe. That's where you're going to find this. So that's we can go to 17. The deep nuclei of the cerebellum include which of the following? A. Globus fastigial emboliform dentate. B. Global substantia nigra dentate red nucleus. C. Dentate fastigial caudate globus pallidus. D. Caudate globus pallidus substantia nigra dentate. Which ones are the deep cerebellar nuclei? A. Thank you so much. What's the mnemonic? Don't eat what? Don't eat greasy food. 18. The initial three swelling on the rostral end of the developing embryo includes all of the following except rhombencephalon, metencephalon, prosencephalon, mesencephalon. Which one is the exception? Metencephalon. Thank you so much. Let's just describe for the sake of sake. The forebrain comes from which part? Which one is the primary vesicle for the forebrain? Thank you. Prosencephalon. So we have got the prosencephalon. And then for the midbrain, we have got what? Mesencephalon. And then for the hindbrain, rhombencephalon. Okay. So the way I remember this for myself is that Mess, M is mid. So just remember that mid, M, midbrain. And then now I'll be comparing between P and R. I know that P comes first in the alphabet than R. So P is going to be from the forebrain. And then the R, that is going to be the hindbrain. So later on, these are going to develop into secondary brain swellings. The prosencephalon is going to divide into two. The mesencephalon remains as the mesencephalon. The rhombencephalon divides into two. Let's start with the prosencephalon. Which two does it divide into? Yes. And which one? So it will divide into the cerebrum. Which other part, docs? And the diencephalon. Thank you so much. So those are also known as the telencephalon and the thalamencephalon. The cerebrum and the diencephalon. So the cerebrum is the telencephalon, diencephalon is the thalamencephalon. The mesencephalon will still remain as the mesencephalon. Rhombencephalon will divide into three: myencephalon and metencephalon. Myencephalon and metencephalon. The myencephalon forms the medulla oblongata. Metencephalon will form the pons and the cerebellum. So those are the basic things. Number 19. In which one of the following do axons carrying visual information synapse? Medial geniculate nucleus, lateral geniculate nucleus, ventral geniculate nucleus, none of the above. Th- Thank you so much. LGB. Decussation of pyramidal tracts occur in which of the following structures? Lower spinal cord, upper spinal cord, medulla, pons. Anyone? Medulla. Thank you so much. Remember, it's in the medulla where we're finding the pyramid, and that's where I've got a point of decussation. Cell bodies for the motor supply of the trigeminal nucleus lie in which of the following? Hypothalamus, midbrain, posterior to cerebral aqueduct, cerebral cortex. Anyone that can help with this one? The midbrain, right? Thank you so much. So that's the midbrain, isn't it? For the trigeminal, the cell bodies. Regarding the retina of the eye, the following is true. Ora serrata demarcates pigmented from non-pigmented retina. Optical retina is anterior, while non-optical retina is posterior. Retinal cells send impulses to epiphysis cerebri. In retinal detachment, the retina detaches from choroid. Anyone to help with this one? Thank you so much, Doc. Anyone else? So the doc has picked D, that in rational detachment. Yes, please. D as well. Okay. Mm, retinal detachment. All right. So hope we are all fine with D. Okay. So let's start with the option A. Ora serrata demarcates pigmented from non-pigmented area. Anyone that knows anything to do with oro serrata? Anyone? Anything that you know? Okay, so the ora serrata is a junction between the retina and the ciliary body, not between. Remember the retina, when you're talking about the layers of the eye, we said that the eye is going to have the outer fibrous layer, isn't it? Which is divided into anterior, you are going to have the cornea, right? Which is 1/5, 1/6, and then you are going to have the posterior aspect, the continuation. Which one is that? Is that the sclera? And then you are going to have the second layer, that is vascular layer, where you have got the choroid at the back. And then as you go anteriorly, you are going to be having the like the that body. What's the name of that body that contains those muscles? Ciliary body. Okay, ciliary body and those muscles. And then you are now going to have the retina. The retina has got the pigmented layer and the neural layer. Pigmented is where you find the rods and the cones. Okay. So the oral serrata is a distinction or the separation between. Remember, when you're talking about this is a choroid. After the choroid is the second layer, because outside here you have got the this is outside, you have got the sclera, and then this is the choroid. Now as you go more inside, now you are going to have the retina. For the retina, we first start with the neuroretina, the pigmented layer first. Okay, the pigment. These are the pigments. And then now we're going to have the neuro, which are the rods and the cones, the rods and the cones, which will be connected to the bipolars, and then the bipolars will be connected to the other cells. So here, the distinction, so I've got different distinctions. The oral serrata is a difference between the ciliary body, specifically in front. Let's say this is in front, right? Let's say this is the front, because the continuation of the choroid is the ciliary body. So we can say this is the same ciliary body. So just this point where these guys, you can differentiate them. That's the oral serrata. Not this point where you are distinguishing, where you're separating uh, the pigmented retina from the neuroretina. No. So that's why A is not correct. And then B, optical retina is anterior while non-optical retina is posterior. Anyone that can disqualify this option? Now you know the optical retina. Optical, this is you where light is dropping, and you know that light is coming from the front of the eye, is going to drop at the back. That's at the back. So the optical retina is at the back, not anterior. Retinal cells send impulses to epiphyseal cerebri. Now we know that for the retina, after you pick up these visual sensations, where do we project? Which part of the brain do we project to? Do we go to the pituitary gland? Because we go first to the L, to which part? Not LGB. We are going to be going to the occipital lobe, isn't it? But yes, we first go to the LGB and then we go to the occipital lobe, right? Not to the pituitary gland. No connection there. That is why we are going with that. Is that fine? Next question. Fibers from the corpus callosum which radiate into the temporal lobe form A. Forceps minor, B. Forceps major, C. Tapetum, D. Forceps anterior. Anyone that can help with this one? Anyone? Okay, say this is, we know the corpus callosum. It's C. Okay, thank you so much. That's the correct answer. Capetum. So here is our corpus callosum, a structure like that. We know that on what is on top of the corpus callosum? We have got a gyrus. What's the name? I know we are just pretending. The cingulate. Yes. So we are going to have these projections to the frontal lobe. This is going to form what we call forceps minor. And then you are going to have projections coming from the posterior aspect. And these are going to the occipital lobe. That is going to form what is known as forceps. This is minor. This is forceps major. And then you have got the corona radiata. These fibers going like that. And then part of this, you are also going to have those which are going to the temporal lobe, and that's what we call the tapetum. Okay. Number 24. Amygdala's main function is homeostasis, olfaction, memory, emotion. Anyone to help? Emotion, right? Why do you cry when you're eating Nshima? Because you love Nshima too much. Emotions are attached. So you can actually use this mnemonic to know the functions of the limbic system: homeostasis, olfaction, memory, emotion. Homeostasis, mainly the hypothalamus. Olfaction, you have got what we call the anchors. And then memory, you have got the big guy, the hippocampus. Emotion, you have got the amygdala. Concerning the anchors, the following is correct. Is a bump in the hippocampus, has gustatory function, herniation is likely to compress trochlear nerve, ankle herniation results in ipsilateral pupil dilation. Anyone to help with this one? Is a bump in the hippocampus. Okay, when you look at where the anchors is actually part of what is known as the limbic lobe. You remember the parts of the limbic system is going to have a lot of parts. Okay, what are the components of the limbic system? You have got the limbic cortex, you have got the hippocampal formation, you have got the amygdala, olfactory cortex, you have got also the diencephalon. So the diencephalon includes the hypothalamus, the thalamus, specifically the anterior nucleus, and the medial dorsal and the habenula. You have got also the basal ganglia. You've got parts of the basal ganglia that is part of the limbic system, like the nucleus accumbens, the ventral caudate, the putamen, and also you have got the ventral pallidum. Besides that, you also have the basal forebrain, the septal nucleus, and the brainstem. Those are components of the limbic system. The hippocampal formation has got the dentate gyrus, the hippocampus, and the subaculum. Those are three parts. Hippocampal formation, dentate nucleus, hippocampus itself, and subaculum. Now, the limbic lobe, the limbic lobe, has got five many parts. You are going to see this guy like so. It's going to have the parahippocampal gyrus. It's going to have the cingulate gyrus. And then it's going to have the medial orbitofrontal cortex, and then it's going to have also the temporal pole and the anterior insula. Okay, those are the main parts. Of course, you are also going to have the anchors. The anchors. The anchors, you are going to see it somewhere there at the end. But it's more related to the parahippocampal instead of the hippocampus. So that one is out. And how about B? Can it be part of the answers? Anyone? Actually, the ancus is a bump, not in the hippocampus, but in the temporal lobe, near the it's near the hippocampus, not the hippocampus, because the parahippocampus is actually related. Why do we call it parahippocampus? Because it is just next to the hippocampus, parallel. So it is a bump in the temporal lobe. I just mentioned to say on these functions on top. What did we say? Who plays a role in olfaction? Anyone who remembers what we said? Okay, let's start. This is who plays a role in homeostasis in the limbic system? Hypothalamus. Who plays a role in emotion? The amygdala. Who plays a role in memory? Hippocampus. And then who plays a role in olfaction? It's the anchors and some other parts. The same olfactory area. You know the olfactory area is nah, the same olfactory area. Where is the olfactory area? The smelling area. It's in the temporal lobe, isn't it? Yes. That's where the anchors is found. Not gas station. Now, when this guy, because it's found in the temporal, it's a bump in the temporal guy. It's very near to the nucleus of cranial nerve number 3. So if there is any inhalation of this guy, it's going to compress on cranial nerve number 3 nucleus, and that is going to remember the cranial nerve number 3 is involved in pupil movement and also the change in size of the pupil, not pupil movement, eye movement, oculomotor. Remember, we said, I want us to be really reminded of this. Huh? When you have, this is your eye. When you go through the optic nerve goes to its nucleus. It's actually going to send, we had said that it sends fibers that are now going to pick up these other fibers via the oculomotor nerve, and those are going to go back they are going to this eye and going to the other eye, and those are the ones that are responsible, this is oculomotor, for both the consensual and direct pupillary reflex. So meaning that these guys, cranial nerve number 3 controls the size of the pupil. So if there is annihilation of the anchors, there's going to be compression on this nerve, and so that is going to cause ipsilateral pupil dilation. Okay? It's ipsilateral because it is the same side where that effect has happened. It's not compressing before the nerve separates to the right and left. So this one is not true because it's stroke clear. It's actually cranial nerve number 3. Hope that is fine. Number 26. Neurons of the nucleus. Yes, doc. Oh, the answer is D. Ankle initiation results in ipsilateral pupil dilation. We have compressed cranial nerve number 3, and so we can't be able to respond to light stimulation. Neurons of the nucleus dorsalis of Clark give origin to each of the following. I remember I mentioned this one. Spinothalamic tract, grassopfasciculus, dorsal spinocerebellar, ventral spinocerebellar. Which one do we pick? The gracile fasciculus. This is a nucleus of dorsalis, the Clark's nucleus. Okay, let me remind us. I mentioned this when we were talking about fibers which were going to the cerebellum via the peduncle, superior peduncle, inferior peduncle. If you remember, we mentioned for the spinal border cells in lamina 7 that one of these tracts which is going to the cerebellum is going to pass through them. We also mentioned the Clark's nucleus or the nucleus dorsalis as one of those tracts which are going to the cerebellum. Anyone that remembers? So the ventral spinocerebellar is going to have give origin to neurons of the nucleus dorsalis will give origin to the ventrocerebellar tract. Okay, spinocerebellar, and then the dorsal is the one that is passing through lamina 7. All the following structures form part of the cerebellar circuitry except cerebellar peduncle, pontine nucleus, red nucleus, descending motor pathway. Anyone that can help? Descending motor pathway. Thank you. Remember, here is this nice structure. Here you have got the fourth ventricle. Behind you have got this guy, hub vitae, the tree of life, the cerebellum. You have got connections up superior cerebellar peduncle, inferior cerebellar peduncle, mid dorsal and then inferior. So cerebellar circuitry has got these fibers coming from the brainstem going to the cerebellum. Like the pons are in the brainstem, the red nucleus is in the brainstem, including the cerebellar peduncles because they are connecting to the brainstem. The descending motor fibers or pathway, no. A 34-year-old female is diagnosed with locked-in syndrome. Which of the following is not a feature? You know, I really fear locked-in syndrome. Like, let's answer it and then we'll talk a bit about it. Okay, let me talk about it a bit and then someone also add something. I'll say one thing, another person says something that they know about locked-in syndrome. Locked-in syndrome is a bad syndrome because you are alert, but then you are helpless. You can't do anything. Imagine someone, I was watching a movie of someone who was in a locked-in syndrome. The daughter started behaving, it was like a vampire's movie. She got the dad, he was in locked-in syndrome, took him to the shore of the river, wanting to throw him. And the problem is that you 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 are aware, but then you can't do anything. You are helpless. So he was just there, just seated in the chair. You can't move. You can't do anything. That is what I can mention. Anyone else that can add anything that they know about the locked-in. Thank you so much. The eyes are open. They can close and open the eyes, and that's how these people communicate. Just opening. They can open the eyes and move the eyes upward and downwards. Up and down. Vertical movement. Please vertical, not horizontal. Anything else about locked-in syndrome that we know? Anyone else to add anything? Thank you so much. Even the person can understand what you are saying because your system, there is a sparing on your psychological aspect. It's just the motor system affected. They can well understand everything, but the only thing is that they can't speak back because everything to do with motor is paralyzed, except of course because the respiratory centers are in some other part of the brain. The person is still breathing. Otherwise, if that part of the brain was also affected, they can't breathe because the respiratory centers will be disturbed. That is why. So which part of the brain is affected in locked-in syndrome? The ventral pons. Thank you so much. Right, the ventral pons. So here the question is saying a 34-year-old female is diagnosed with locked-in syndrome. Which of the following is not a feature? A. Absent motor function. B. Intact cognition. C. Damage to ventral midbrain. D. Patient able to open eyes. So which one of these is not a feature? We've already talked about everything, guys. Just pick. Pardon? Okay, thank you. C. The problem is not damage to the ventral pons, but to the not to the ventral midbrain, but the ventral pons. And one thing that differentiates locked-in syndrome and a coma is that in a coma, someone's eyes are closed, and it has happened for at least an hour. But in locked-in syndrome, the eyes are open. A 15-year-old Jason Peary is diagnosed with coma. All the following is true to his condition except eyes may be open, has been in this state for at a minimum of 30 minutes, caudal reticular formation may be damaged, midbrain lesion may cause blown pupil. Anyone? Okay, thank you so much. Is there anyone else? Anyone else? Okay, so the answer is A, just like we said earlier. That's what differentiates the condition from locked-in syndrome. For a coma, you are closed. The reticular formation has to do with the same cognition. So here, even understanding, you can't understand you are not awake because when the reticular formation is disturbed. And if there is a damage to the midbrain, there can be a blown pupil. 30. A 45-year-old female has a cerebrovascular accident. What we are just saying is that the artery, there's a problem there. Maybe there was a thrombus or an emboli or something. Assessment reveals the patient has, please take note, fluent speech with impaired comprehension. You are answering, but you don't understand what you were answering to. And impaired repetition. What condition does this patient have? Broca's aphasia, conduction aphasia, Wernicke's aphasia, global aphasia. Thank you so much. Wernicke's aphasia. Anyone that wants to say something about it? Why do you think it can be Wernicke's aphasia? Hmm. Okay. Thank you so much. Anyone that also wants to add in something? Oh, sorry for the previous question. We picked A. Eyes may be open, so the eyes are always closed. Anyone that wants to say something again? Okay. Remember, the Broca's area is the one that is responsible for speech. That is the motor aspect. Okay. While the Wernicke's area is for understanding written and spoken language. So this person can't understand, but they can speak, meaning that the Broca's area is fine, but the Wernicke's area is affected. So that is Wernicke's aphasia. 31. Which of the following is true about the somatosensory cortex? It's located in the postcentral gyrus of the parietal lobe. It receives input from both ipsilateral and contralateral receptors. It has a somatotropic map that is fixed and unchanged, changeable. It is involved only in the perception of touch and pressure. Anyone that can help with this one? A. Thank you so much. It's located in the postcentral gyrus of the parietal lobe. We can try to describe why are these other options wrong. Let's start with B. Receives input from both ipsilateral and contralateral receptors. Why is this one wrong? The badness is we don't want to speak even when we have idea. Okay, 32. Only contralateral. Thank you. Which of the following is a type of mechanoreceptors that detect vibration and fine touch? Pacinian corpuscle, rufine ending, Meckel disc, free nerve ending. Anyone to help us with this one? Okay, Pacinian, that is correct. Pacinian is basically for vibration and touch. How about rufine? Rufine endings. What do they detect? Light touch. Which one else? Okay, the rufine, this guy is more for stretching the skin, right? More for the stretches. And then the Mechios, that's where you're going to find the light touch because Mechios guys are found like very near to the skin, very, very near. So light touch, and you can also use the Mechios to be able to differentiate the edges, points and edges because they are found like especially at the tips of the fingers. That's where they're going to be found. So you can differentiate the points and edges. When you touch, let's say, a table, you can feel okay, this is the edge. And then the free nerve endings, these are more for pain and temperature, conduction, even crude touch. Pain, temperature, crude touch. Crude touch, this is the you can't really feel where someone has touched you, but you can feel someone has touched you. Or let's say, for example, if you are itching, you can't really say this is where it is itching. You are pointing at a bigger area. So that is crude. Which of the following is a characteristic of fast pain? Mediated by A delta fibers, poorly localized and diffuse, associated with emotion and autonomic responses, inhibited by substance P. Anyone that can help with this one? It's A, right? Mediated by A delta. This one poorly diffuse. The diffuse ones are the slow pains. Like diffuse means you can't really point to where the pain is. You are saying it is this area instead of this point. It's associated with emotion. Emotion is more for the slow because it takes more time. Like it is more prolonged. So because it's irritating and it's inhibited by substance P. Pain is actually caused by substance P, not inhibited by substance P because it's a pain neurotransmitter. Which of the following is a mechanism of analgesia in the spinal cord. How do we stop pain in the spinal cord? Activation of descending pathways that release serotonin and norepinephrine, inhibition of presynaptic calcium channels by opioids, blockade of postsynaptic sodium channels by local anesthetics. All of the above. Thank you so much. It's all of the above. So when you look at activation of descending pathways that release pain, so having ascending pathways, they are carrying pain from your muscles going up. The descending pathways are going to be releasing serotonin and norepinephrine, and these are going to be countering the pain that is being produced by the substance P, which is being released by the ascending pathway. Inhibition of presynaptic calcium. If you inhibit calcium from the presynaptic nerve, calcium is involved in the release of neurotransmitters, including those that are going to help in pain sensation. So if you inhibit these, you're not releasing neurotransmitters, so action potential is not sent to be able to feel the pain. C, blockade of postsynaptic sodium. And you know that also sodium is important on the postsynaptic cell. Imagine you've released neurotransmitter, but then you can't open these sodium channels. You can't form an action potential in this guy, the postsynaptic cell, to be able to carry sensations up. So you've inhibited that. So that's all. Which of the following is a function of the thalamus in somatosensation? It relays sensory information to the primary somatosensory cortex. It integrates sensory information from different modalities. It modulates sensory information based on attention and arousal. All of the above. Anyone? Okay, we know that the thalamus will be. Please, Doc, you can go on. Okay, thank you so much. Do you want to also say why? Okay. So remember, this is our cerebrum. Here is our thalamus. Let's say we are taking information from the eye to pass through here, the LGB, and then go there. So it relays sensory information to the primary somatosensory cortex. There's only one that is not going to pass through the thalamus. Which one is that one? Anyone that knows it? Is of action. And then it integrates sensory information from different modalities. We know that, isn't it? From all the modalities, pain and those things. It modulates sensory information based on attention and arousal. Which of the following is true about phototransduction cascade? It involves the activation of phosphodiesterase by transducin, involves the hydrolysis of CGMP by phospholipase C, involves opening of sodium channels by cyclic adenosine monophosphate. It involves closing of potassium channels by inositol triphosphate. Anyone that can help with this one? Anyone? It involves the activation of phosphodiesterase. Do you want to explain why? Okay. So what is happening is that when it is, in the dark, the rods and the cones, these guys, they are more, the rods in the dark are the ones that are more active, and the cones are less active, right? So that is what happens in the dark. And in light, what is going to happen is that, let's say here is our rod or our cone. It has got the outer segment, and then it has got the inner segment, and then the synaptic end. Let's say this is how it is. So when light strikes the outer segment, let's say this is the outer segment, light strikes there. Remember, this is in light. reactions are going to initiate the closure of sodium channels. And when the sodium channels close, there's going to be hyperpolarization because you have got little positivity inside the cell. And when there's hyperpolarization, there's going to be a reduction in the release of the neurotransmitter. And that leads to the inhibition of the bipolar cells because remember these guys, the cones, are going to be attached to the bipolar cells. So because you have not released the neurotransmitter, there is a reduction in the inhibition of bipolar cells because actually what these guys do is that they're going to release GABA to inhibit the bipolar. But since there is no release of GABA, these guys are not inhibited. Since the bipolars are not inhibited, they are now going to release their glutamate, which is going to stimulate the ganglion cells. And when the ganglion cells are stimulated, they are also going to release their neurotransmitter, and then action potential is going to be transmitted to the brain. Okay. But then remember, we said that is closure of the sodium channels. But how? How does the closure of the sodium channels happen? So what happens that when light hits this outer segment of the cones, can remove this. When light hits the outer segment of the cones, it's going to change retina, retinal. So retinal is found in different forms. You have got what is known as 11 cis retinal, which is also known as retinine 1. And when light hits the outer segment, it's going to convert this retinine 1 or 11 cis retinal to O trans retinal or trans isomer. And when you transform from 11 cis to O trans, that is going to change the configuration of opsin, which is a photopigment. So the photopigment, so in the eye you have got rhodopsin, which is the actual photopigment. Rhodopsin has got a protein known as opsin, which is also known as a scotopsin, which comes from retina. So the conversion of 11 cis retinal to our trans retinal is going to change the conformation of opsin or scotopsin. Scotopsin. And when that conformational change happens, what is going to happen is that that opsin that has changed conformation is now going to get the transducin. Transducin here is inhibited. It's now going to be stimulated. Okay, it's going to be activated by opsin, which has changed conformation. That opsin has got alpha segment, beta segment, and the gamma segment. So what happens that the alpha segment is going to get that G piece normally attached to it to remove it and then get GTP. So the transducin now that is active, you have got the alpha segment that is now attached to GTP. This alpha segment is now going to go and get to activate cyclic guanosine monophosphate phosphodiesterase. So this guy is going to activate CGMP phosphodiesterase. Now, phosphodiesterase enzyme is the enzyme that breaks down CGMP into its inactive form, which is 5-GMP or guanosine monophosphate. When you reduce guanosine monophosphate, remember yesterday we talked about asthma. We said that guanosine monophosphate causes contraction. Not guanosine monophosphate, but cyclic adenosine monophosphate, CAMP. But CGMP is important in opening sodium channels. So if you decrease this concentration because you're converting it to this form, that is going to close the sodium channel. So that is how the sodium channels close. So it involves the activation of phosphodiesterase by transducin. You know that is true, isn't it? Okay, the following is true about phosphor. And then B saying it involves hydrolysis of CGMP by phospholipase. We know it's not by phospholipase. C is saying it involves opening of sodium channels by CMP. It's not CAMP, it's actually CGMP, right? And it's not even this guy. Yeah, it's not CAMP. It involves closing of potassium channels. It's also not that. So that's why. Question 37. We are ending at 40. Which of the following is true about the visual pathway in the brain? The optic nerve carries information from both eyes. Sorry, just a moment. All right. So, which of the following is true about the visual pathway in the brain? A. The optic nerve carries information from both eyes. B. The optic tract carries information from the ipsilateral eye. C. The lateral genetic nucleus is part of the thalamus. D. Primary visual cortex is located in the temporal lobe. Anyone that can help with this one is C, right? Lateral genetic nucleus is part of the thalamus. Why not A? Optic nerve carries information from both eyes. Why is that not correct? Mhm. Thank you so much. That's it. So look at these two guys that we are drawing here. So this is the optic nerve. You can see it's only carrying information from one eye. That's why this is not true. The optic tract carries information from the ipsilateral, and this is the tract. You can see the tract is carrying information from both the left eye and the right. So that's not true. Primary visual cortex is in the occipital 38. Which of the following is true about color vision? It's mediated by three types of cones with different spectral sensitivities. It's mediated by rods that can distinguish different wavelength of light. It's mediated by single type of cone that can vary its pigment composition. It's mediated by bipolar cells that can compare inputs from different photoreceptors. Anyone that can help with this one? Hey, thank you so much. So color is mediated by three different cones. What are the three names? What are the names of the three different types of cones that mediate color vision? So these are the guys: anopsin that is responsible for blue color, iodopsin which is responsible for green color, and hypothropsin which is responsible for red color. Which of the following is true about accommodation? Which of the following which of the following is true about accommodation? A. It is the process of adjusting the shape of the lens to focus on near objects. B. It's a process of adjusting the pupil size to control the amount of light entering eye. C. It is a process of adjusting the position of the eye to align the image on both retinas. D. It is a process of adjusting the sensitivity of the photoreceptors to adapt to different light levels. Anyone that can help? So we have got A and B. Let's start with the dog that has picked A. Would you love to explain why you've picked A? It is a process of adjusting the shape of the lens to focus on near objects. Would you help why? Okay, how about the dog that picked B? Would you have to explain? Okay, you can go on, please. Thank you so much. So, response of the pupil is a pupillary light reflex, but about accommodation is the eye changing shape. So, let's say, for example, when you are look, this is your eye, this is your lens. You have got this is your retina. You have got light rays which are going like this. When they reach here, they are going to turn like that. You can see for here you are forming an object near here, and specifically you are looking at an object that is far. So you can't see an object that is far. But if this object was near, you could see. So what condition is this? You can't see far, but you can see near. What is the condition? Anyone? Pardon? Myopia. All right. Thank you so much. So you can see near, but you can't see far. That's myopia or short-sightedness. So how you are going to correct this mistake is that for that same object that you are looking at that is far, simply bring a lens that is like this, biconcave. Because what this lens does is that the light that you're supposed to just be going like this, it will be turned a bit. To be turned a bit. Let me draw that again. So there is some form of, instead of it just going straight like that, it is going to bend less. Okay, it's going to bend less. So you see, it is going to go and meet at the very end there. So that is by convex. That's the treatment for myopia. But if we had short-sightedness, let's say here is the object, or long-sightedness, sorry, you can see things which are not near, and here is your lens. So when you look at this, the lens can't bend the object very much. So because it can't bend very much, the object is forming behind the retina. So when you want to correct this, introduce another lens that is going to help in bending again. Okay, because you have got this prism plus you have got your eye here. So here you are going to introduce a biconvex lens, and then you have got also the lens of your eye. So what you are going to do is that this one is going to help push, because I should have actually shown this one like this. This one, as you are going, is going to push the object like this. The rays are now going to be pushed a bit out like this. The rays are pushed a bit out, and then now it will be able to come and merge. But for this one, it will bend the object, and then it will come and bend more. Even here, it will bend, and then it will come and bend more. So you end up now coming here instead of going past. So you use a biconvex for farsightedness, hyperopia. The last question, 40. Which of the following is true about visual acuity? Say highest in the fovea where there is high density of rods, highest in the periphery where there is a high convergence of photoreceptors, highest in daytime where there is a high activation of cones, highest in darkness where there is high activation of rods. Anyone that can help with this one? Visual acuity, where there is high activation of cones. Okay, let's be disqualifying the options. Highest in the fovea where there is high density of rods. Of course, it's highest in the fovea, but not because there are rods, it's because of the cones. because visual acuity is about light. Highest in the periphery where there is high convergence, not in the periphery, because in the periphery I've got more of the rods. Highest in daytime where there is high activation of the cones, that's correct. Highest in darkness where there is high activation of the rods, no. Of course, in the darkness there's high activation of the rods, but that's not what is responsible for visual acuity. Acuity is being able to differentiate, to be able to really tell the ends or the edges. For example, if you are looking at your finger, start moving it to the corners, you can really see where it is going to end. So here we end for now.